Good morning, everybody. Thank you for asking me to be part of this Opus Forum meeting, and to Peter Chung and the organisers for inviting me specifically. I've been asked to provide the surgical perspective to femoroacetabular impingement treatment. Joe Kemp will provide a physiotherapy perspective, and hopefully between us during the panel discussion, we'll be able to provide a balanced view of where the two fit together. It's been said that femoroacetabular impingement is a new condition only recently discovered, possibly by surgeons. And is this true? Well, of course, no, it's not. This is the earliest description I can find of impingement surgery, and this was published in German literature in 1913. You can see the picture here with the cam lesion and the surgical treatment of that, of course, by open surgery. Marius Smith-Peterson in 1936 published in the Journal of Bone and Joint Surgery a series of impingement operations which were done for both what we would now term pincer impingement, seen here with the red line marking the resection around the acetabular rim, and here of a cam lesion showing removal of part of the femoral head and neck junction. Bear in mind, this surgery was done in 1934 and published in 1936. And Ronald Murray, a British radiologist, published in 1965 his description of what he termed the pistol grip deformity of the proximal femur. This is in fact a cam lesion seen on an AP X-ray. And most importantly, he stated that 65% of so-called primary osteoarthritis, that is osteoarthritis with no apparent cause, was in reality secondary to a pre-existing asymptomatic anatomical abnormality, as he described it. All of this was drawn together into a much more coherent form by Reinhold Ganz and his co-workers in Bern in Switzerland in the 1990s and early 2000s, and published in the early 2000s in landmark papers, two of which are shown here, particularly describing how these different forms of impingement were associated with the development of osteoarthritis in later life. Ganz described both cam and pincer types of femoroacetabular impingement, with a cam lesion seen at the top right, consisting of excessive bone formed at the femoral head-neck junction, both, well, most typically anteriorly, anterosuperiorly, and superiorly, but of variable extent and sometimes circumferential. Pincer deformity, on the other hand, is where there is excessive bone at the acetabular rim and margin, and of course there can be a combination of the two. This is a depiction of how cam works. You can see the yellow cam lesion with rotation of the femoral head. The cam comes into contact at the junction of the labrum and the articular cartilage here, and that this then leads to shearing stress, separation of the labrum from the acetabular articular cartilage, and delamination of the articular cartilage. The pincer lesion, on the other hand, has a prominent acetabular rim. The labrum gets crushed between the bone of the acetabulum and the femoral head and neck. There will be damage to the articular cartilage at the edge of the acetabulum, and there may be a development of a reactive bony lesion on the femoral neck as well. There's been considerable confusion regarding the terminology, and in 2016, a large group of us, including surgeons, physiotherapists, sports doctors, radiologists, patient, got together to try to come up with a coherent system, and this was published in the British Journal of Sports Medicine. One of the important things that I'd like to draw to your attention is that in order to have a diagnosis of femoroacetabular impingement syndrome, there are three requirements. There must be symptoms, there must be signs, and there must be consistent imaging findings. And the symptom which will be present in everybody is pain. There will be others perhaps, but there will be pain present, and one cannot have a diagnosis of femoroacetabular impingement syndrome without pain. It's therefore not possible for a radiologist to diagnose femoroacetabular impingement, and to talk about asymptomatic femoroacetabular impingement is probably not sensible either. Does this matter? Well, yes, it does, because there's an association which has been well shown in longer term papers between the presence of cam lesions particularly and the development of osteoarthritis. This is one such study which was done in the UK over a 19-year period. It was a group of women between the ages of 45 and 65 initially, who were studied particularly in regard to osteoporosis. But it happens that they had X-rays taken at the beginning of the study, which could then be checked later. and determined if they had any signs of problems present at the start which were associated with an increased likelihood of developing osteoarthritis. It happens that there were two, the presence of a CAM lesion or the presence of acetabular dysplasia, both of which are associated with a much stronger likelihood of developing osteoarthritis. And in fact, the size of the CAM lesion as measured by an alpha angle was linearly associated with an increased risk of developing developing arthritis and requiring total hip replacement by 19 years. A similar study done over a 5-year period in the Netherlands showed the same thing, where CAM impingement was strongly related to the development of hip osteoarthritis. What is it that we see? So at arthroscopy, one of the earliest signs of damage associated with a CAM lesion and causing pain is destruction of the chondrolabral junction here at the acetabular edge. The labrum is torn, the articular cartilage is separated from the labrum and starts to delaminate. Here over quite a small area, this is about 1.5 centimetres in length, but this grows with time. So that with increasing damage, the articular cartilage starts to peel away, large areas of underlying bone are exposed. This is osteoarthritis of the hip. How do we deal with this? In the early stages, if we get to it before there is major damage to the articular cartilage, one of the things we need to do is to remove this lump of bone which is causing the damage. This is on a CT scan. This is the same patient seen at arthroscopy. So we need to burr away the excessive bone, which is all just outside the joint anyway. We can, if necessary, follow an image intensifier to be sure that we're removing bone in the correct space and regaining the correct shape. With a pincer lesion, it's a little different. The diagnosis is made preoperatively because it's harder to see the piece of bone. Often there's a hypoplastic labrum, as here, it's quite small, it's frayed. This is where it's been getting crushed between the bone of the acetabular rim and the femoral neck. The labrum needs to be peeled away a little from the top of the bone, as seen here, and then this bone is burred away. If the junction between the articular cartilage and the labrum remains intact, then that can be left. But if they separate, leaving a labral tear, as seen here, then that labrum needs to be repaired with a series of anchors placed in the bone and sutures passed through the labrum, tied outside the labrum and replacing it in its proper position. Does this surgery work? There are now a large number of papers published which predominantly demonstrate that femoroacetabular impingement surgery leads to marked improvement on average in objective signs, pain levels, and activity levels for patients. These are all described as lower-level evidence studies, and they're often retrospective reviews, and so they're open to criticisms of potential bias. However, they do pretty much all point in the same direction. Here's an example of one such, which is a study that we did in 2008 to 10, looking at a group of Australian Football League players, so all top-level players, who all had this surgery performed. We followed them at this stage up to 4 years. And what we found was that, of course, initially there was a marked drop-off after surgery, but by 6 weeks, they were back almost to the level they'd been prior to surgery. They mostly resumed playing at around about 3 months. And at 1 year, they'd got close to their ultimate goal. This was maintained at 2 years and indeed improved a little further. And it was then maintained at 4. And when we followed them up in a second paper, at 8 years following surgery, we found that improvement was still maintained, although all of them had stopped playing by that time. The average length of a footballer's life in football is 4 years. Does the surgery work for longer? Well, there's a limit to how far we can go with patients with this type of surgery, as the early ones were done mainly in the 1990s and beyond. But there are 10-year results available for open surgery, which show that for patients followed for 10 years, 80% of them have not had hip replacements and on X-ray have no sign of developing arthritis. 10% have had hip replacements and 10% have earlier signs of arthritis, which is developing. A similar study done over 10 years on arthroscopy patients showed similar findings, and in fact, a little better. These patients were selected a few years later when arthroscopy had really come of age, and so the selection criteria were a little tighter. Systematic reviews have been done in numbers, and this is one where over a group of nearly 2,000 patients followed for 30 months and more, that all of these various scores showed marked improvement, and the postoperative pain and the pain levels, the visual analog scales, have dropped away to very low numbers. There are registry data available from both the Danish registry seen here and the UK registry, which is similar. And again, these show improvement in the various domains of the Hagos score, which has improved significantly at 1 year and continues to be maintained and indeed improve a little more at 2 years, as we saw previously with our group. There are a number of RCTs now which show similar findings. I won't dwell on all of them. The first was done in America on a group of military personnel. This is rather a weird one because 26 of the physio patients crossed over during the study onto surgery. So in fact, they were comparing 66 patients with surgery with 14 with physio. They were an odd group. They started off on very low numbers and they really behaved more like a group of work care patients than a group of athletes. The first of the well-structured RCTs was the fashion study in the UK. This has been published at 1 year from the time of randomisation. So a number of the surgical patients being in the NHS hadn't actually had their operation at the time when the follow-up was done, but it's an ongoing study which will report into the future. And this showed improvement in both the physiotherapy and the surgical groups, surgical group being a little higher. Similar finding in a study that was done at Oxford using different endpoints and scoring systems, but showing similar changes. We've performed a similar study to the UK fashion study here. It's in the process of being published now, comparing physiotherapy with surgery. Results are at 1 year from the time of commencement of treatment and using the same scoring system, the IHOT 33. And again, you can see there are improvements in both the physiotherapy group and the surgery group. The surgery group is somewhat higher. So in summary, once symptoms develop, femoroacetabular impingement symptoms deteriorate. Patients with significant CAMs are much more likely to develop osteoarthritis. It's important to emphasise that not everyone with a CAM will develop arthritis, and indeed the majority will not, but a significant number will. And the more active the people are and the larger the CAM lesions are, the more likely that association will be present. Surgery leads to significant improvement in around 90% of carefully selected patients. This improvement is largely maintained, greater than 80%, for at least 10 years, with no sign at that time of developing osteoarthritis. So that would certainly seem to be a significant improvement. There are important roles for both physiotherapy and surgery, and these roles have not been fully defined as yet. Randomised controlled trials are extremely expensive. Ours cost around $1 million, and that kind of money is simply not available for large numbers of trials. They're also incredibly time consuming, and they do not provide a generalised answer to any question. They merely provide an answer to one very specific question and with a large number of built-in assumptions. So I don't think that RCTs are the be-all and end-all, important as they are. And finally, patients with femoroacetabular impingement syndrome, that is, they have symptoms. They will deteriorate without adequate treatment. I believe that our job is to find the best treatment for each individual patient, be that physiotherapy, surgery, or a combination of the two, so that we can give the best possible treatment and obtain the best outcome for each individual person. Thank you very much.